So next we'll go to the examination of sensory nervous system examination. Hello, namaste students. So till now we have discussed in central nervous system examination the higher mental functions, cranial nerves. In the motor system examination we have discussed nutrition, tone, the power examination, coordination we have discussed. Okay. After the coordination, we discussed about the reflexes. After the reflexes, involuntary movements we have discussed. So, next in the examination of central nervous system is sensory system examination. Dear students, till now I have been telling throughout the CNS examination, the anatomy is the most important thing in examination. So, you should know detailed anatomy of the central nervous system to understand the examination part and logically interpret it. So, today, before going to examine sensory nervous system examination, we'll discuss briefly about the anatomy of the sensory nervous system and sensory tracts. Okay, right. So, these are the sensory tracts, students. So, here you can make out this is the dorsal ganglia. This is the dorsal ganglia. Okay. From the dorsal ganglia, the fibers which carry the pain and temperature, you can see here. These are the fibers which carry the pain and temperature, which cross in the spinal cord. The synapse in the dorsal horn, the second order neuron crosses. Remember, in central nervous system always, it is a second order neuron which crosses here. Okay. So, here this dorsal ganglia is a first order neuron. Synapse, okay, in the dorsal horn. The second order neuron crosses in the spinal cord, okay, and then after crossing here in the central, in the spinal cord, it ascends up as a spinothalamic tract. So you can see here spinothalamic tract, okay, it is ascending here, and then it goes and synapse in the ventral posterolateral nucleus of the thalamus, okay, thalamus. From the thalamus, the fibers will be projected to the sensory area of the cortex, sensory association area. Okay, so this is the one tract, okay, the spinothalamic tract which crosses here, okay, in within the spinal cord. So because it is nearer to here the spinal central canal, the intramedullary tumors like syringomyelia will damage the pain and temperature fibers. Okay, it will damage the pain and temperature fibers very early. Okay, right. So next fibers are these are, okay, this is the dorsal ganglia which carries a fine touch, proprioception and vibration. Okay, they ascend, they won't synapse in the spinal cord, they ascend in the spinal cord as a posterior column. Okay, that is a posterior column, nucleus of gall and burdock. Okay, they ascend within the spinal cord and then they synapse in the nucleus gracilis and cuneatus in the medulla. Okay, so from the nucleus gracilis and cuneatus in the medulla, the fibers will cross to the opposite side. Okay, the fibers will cross to the opposite side. See here, the fibers will cross to the opposite side. They are crossing here. Okay, and then ascend in the medial lemniscus and the synapse in the thalamus. Okay, they ascend in the medial lemniscus and they synapse in the thalamus here. From the thalamus, the fibers will be projected to the sensory cortex of the brain. This is about the body. So already we have discussed about the fifth nerve, the phase, the nervous supply, sensory nervous supply of the phase we already discussed. So here what happens is, see here, this is the fifth nerve nuclei, this is the ganglia, so which carry the fibers of the pain and temperature, they descend down. Okay, so here they come here, they descend down here, okay, in the till the spinal C2, C3 level. They cross to the opposite side and then they ascend here Okay, similarly the fibers carrying the fine touch from the phase, okay, they'll synapse, okay, in the cranial nerve nuclei, fifth general sensory nuclei. From the general sensory nuclei, the fibers will cross and then they go to the thalamus. From the thalamus, the fibers will be projected to the sensory cortex of the brain. Okay, so this is the sensory tracts of the body, including the face and the body. Okay, right. So let us go to the tactile pathway once again in detail. So tactile pathway, the one which carries the fine touch. Okay, also proprioception, the same pathway, the vibration. Okay, joint position and position sensation. So here you can make out this is the dorsal ganglion here. The fibers, okay, will go here. They won't synapse, but they ascend till the medulla here. In the medulla, see here you can see the decussation. They decussate to the opposite side here. Okay, they decussate to the opposite side. Then they ascend and then they go to the thalamus here. From the thalamus, you can see it's projected to the cortex. It is projected to the cortex. Okay, you can see the arrow mark there. It is projected to the cortex. Okay. Next, the fibers carrying the pain and temperature, you can see the synapse in the dorsal ganglia cross to the opposite side, then they ascend as spinothalamic tract, okay, see spinothalamic tract, then they ascend, then the synapse in the thalamus, and then they project to the sensory cortex of the brain. Okay, so same thing here in the fifth nerve, you can see here the fibers carrying the pain and temperature descend till C2, C3, crosses to the opposite side, then they ascend and the synapse in the thalamus and they project to the brain. Or the fibers carrying the general sensation from the face, the synapse in the pons, okay, and then they cross to the opposite side, and then the synapse in the thalamus and that will be projected to the cortex. Okay, this diagram is showing both the tactile pathway and pain and temperature pathway, the spinothalamic tract. Next, I'll go to spinothalamic tract single, isolated, how it is depicted here. So here I'll discuss about, okay, the spinothalamic tract. This is the dorsal ganglia. The dorsal ganglia will go, the fibers carrying the pain and temperature will synapse in the dorsal horn. They cross to the opposite side and then they ascend here. As a spinothalamic tract, lateral spinothalamic tract. Then they go and synapse in the thalamus and it will project to the cortex. The pain and temperature fibers carrying from the fifth nerve, as I told, will come descend till the C2, C3 level, then cross to the opposite side, then go and synapse in the thalamus, and from thalamus, the fibers will be projected to the sensory cortex. Okay, right. So, how are the arrangement of fibers in the spinal cord of all these touch, pain, temperature? Okay. So, here you can make out this is the pain and temperature fibers. Here, the pink color ones are pain and temperature fibers. You can see sacral fibers are laterally situated, okay, and you can see the cervical fibers are medially situated, the sacral fibers are laterally situated, the pain and temperature fibers, okay. So that is why if any intramedullary lesion is there, the last fibers to affect are the sacral fibers, that is sacral sparing will be there. Sacral sparing is a feature of intramedullary tumors like syringomelia, ependymoma, because sacral fibers are peripherally situated. Okay, right. Now coming to the posterior column, the fine touch, vibration and proprioception. Here the sacral fibers are medially situated, cervical fibers are laterally situated. Okay, sacral are medially situated, cervical is laterally situated. Okay, and corticospinal tracts, okay, behaves like a spinothalamic tract only, the fibers, that is cervical fibers are medially situated, and the thoracic, lateral and sacral will be laterally situated. These are the arrangement of fibers within the spinal cord. Okay, right. So sacral sparing is an important phenomenon. Why it occurs? You see, because of this arrangement of fibers. Okay, sacral fibers are situated away for the pain and temperature. That is the sacral sparing is a feature of intramedullary only for pain and temperature. Okay. Before going to the examination of the patient of the sensory nervous system examination, so I already told you about the little anatomy about the sensory nervous system, what are all the tracts, and that is very basic before you go and examine on him. Sensory nerve fibers have the nociceptors which carries the pain, they are naked nerve free nerve endings. Then there are mechanoreceptors which are the receptors are Meissner's, Pacinian, Merkel's, Ruffini and Cross. There are some terminologies which we use in the sensory nervous system examination. I just want to tell what are those terminologies. There are three terminologies: allodynia, hyperalgesia, hyperpathia. All the three increase sensitivity to pain. allodynia, hyperalgesia, hyperpathia. Increased sensitivity to pain. What is allosthesia? Allosthesia is if you touch at one part of the body, the sensation is perceived at a different part of the body. That is allosthesia. What is palästhesia? Palästhesia is loss of sensation of the vibration is palästhesia. What is paresthesia? Paresthesia is sensing the sensation, pins and needles, without even the stimuli. There won't be any stimuli, patient will feel the sensation. That is paresthesia. So the different terminologies: hyperalgesia with the increased sensitivity to the pain, hyperalgesia with the decreased sensitivity to the pain, okay, analgesia, total loss of pain sensation, analgesia, anesthesia, loss of sensation of all the modalities, not only pain, all the modalities, allocharia, one part of the body will stimulate and the other part you will sense it, allocharia. Okay, these are the different terminologies which usually use in nervous system examination. Okay, now we have already told about the anatomical pathways in the nervous system examination. Before examining, I just want to show you which are the dermatomes in the body which represent, along which dermatomes you will examine the patient. Okay, see, C1 has no sensory supply outside, it supplies the posterior cranial fossa, C1. C2 supplies the angle of jaw, C2. C3 and C4 cervical plexus, it supplies the neck, cervical plexus. C5 deltoid region. C6 lateral part of the arm. C7 lateral part of the forearm. C8 middle finger. T1 medial part of the forearm. T2 medial part of the arm. T3 is axilla, T4 is nipple. Then coming here, epigastric, umbilicus and suprapubic region. T8 epigastric, T10 umbilicus, T12 suprapubic region. Next, lower limb. L1, if a person stands with both the hands in his pocket, that is L1. Next, below is L2 and patella is L3. Patella is L3. Next, the leg. I'll show on him the leg, the nerve supply. This is L3 patella. This is L4. L4. L5 is lateral part of the leg. L5. S1 here the dorsum of the foot and sole. S1. S2 is the thin rim here from down to up. S2. A thin rim down to earth. Down to up, down to up. S2. S3, S4, S5 surrounding the anus. So simple, okay? And I'll tell, if a person stands like this is L1. If he squats, the whole back, that is S2. And if he sits on his buttock on the ground, it is S3, S4, S5. S2, S3, S4. If he sits on the buttocks, S2, S3, S4. Then there is a rule of 3, okay, rule of 3. The neck is supplied by C3, the axilla is supplied by T3, the knee is supplied by L3, anal region is supplied by S3, okay. The neck is supplied by C3, the axilla is supplied by T3, knee is L3, anal region is S3. So with this anatomical background, we will examine first the posterior column sensation. Which are the posterior column sensation? I told fine touch, vibration, joint position and position sensation. These are the posterior column sensations. Now, which are the lateral spinothalamic fibers carry pain and temperature? There is no need to test both pain and temperature because both the fibers are carried by the same fibers. If you test for pain, that is enough. No need to test separately for temperature. So first we will check the posterior column, fine touch, vibration, position sensation and joint position sensation. So dear students, we will start with examination of C2 angle of jaw. From there we will go till S2. Okay, right. आंख बंद करना. And the sensory nervous system examination, if it is abnormal, should be always from abnormal to normal, and patient should close the eyes. He should say either yes or one, whatever, if he appreciate the sensation. आंख बंद करना. अगर मालूम हुआ तो एक एक बोलना. आंख कभी खोलना, खोलना मत.
One.
Yes. This is C2 I am examining.
One.
Now C3 and C4 neck I will come.
One.
Yeah, this is normal.
One.
Yeah, now I will examine C5.
One. One.
C6 I will examine.
One. One.
C7.
One. One.
C8.
One. One.
T1.
One. One.
T2.
One.
T3 is axilla. Let us examine on the T4. Thoda.
One. One.
T4 nipple.
One. One.
T8.
One.
T10.
One.
T12. Now I will examine L1 lower limb. Now L1.
One. 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 One.
L2 that is.
One. One.
L3.
One. One.
L4.
One. One.
L5.
One.
S1.
One. One.
S2.
One.
Then S3, S4, S4 surrounding the anus. Okay, this is a touch examination, fine touch. Now let us examine the vibration sensation. Posterior column sensations is fine touch, vibration, position sensation, and joint position. First we will finish the posterior column, then we will go to the pain and temperature, spinothalamic tract. Dear students, the examination of the vibration should be with 128 Hertz tuning fork. Okay, you should put over the bony prominences. Okay, olecranon process, medial condyle, then stellar process, patella, medial malleolus. So we will see whether you can appreciate. ये जब रखता हूँ ऐसा होता है ना, उस तरह का मालूम होता तो एक एक बोलना. जस्ट ये टच नहीं, इस तरह का सेंसेशन होता है ना, तब वो एक एक बोलना अगर मालूम हुआ तो. आंख बंद करना.
One. 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 One.
Stellar process,
One.
anterior superior iliac spine,
One. One.
now we will do on the patella. Yeah.
One. One.
Then tibial tuberosity,
One. One.
then medial and lateral malleolus,
One. One.
then ball of great toe you can do.
One. One.
Yeah, so this is a vibration. One more thing in vibration which you can do is on the spinous process you can put onto the level of lesion is spinal cord, at what level there is transaction. So we'll do that. Now we'll make him sit and we'll do that. Yeah, one of the important thing in the vibration sensation which will be useful is on the spinous process you can look for the vibration sensation. If any loss at one level, it give a clue at that level there is a spinal cord is involved. Okay, right.
One. 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 One.
Okay. Okay. Now you you saw how to examine the fine touch and vibration. Let us examine the other two proprioception, position sensation and joint position sensation. How to examine the position sensation? You keep one arm in one position, ask him to put the other arm in the same position. Okay, let us see whether he will be able to do it. आंख बंद करो, आपका ये हाथ कैसा है उसी तरह उस साथ करिए, ठीक है। ये हाथ कैसा है उसी तरह उस साथ करिए, ठीक। आंख खोलिए। दिस इज अ पोजिशन सेंसेशन। ओके, नेक्स्ट इज जॉइंट पोजिशन सेंसेशन। विल डू इट, हाउ टू डू इट, हाउ टू एग्जामिन। ओके, जॉइंट पोजिशन सेंसेशन। ओके, नाउ आई विल टेल हाउ टू डू इट। आंख खोलिए, ये नीचे ये ऊपर, ये नीचे ये ऊपर, ये नीचे ये ऊपर। आंख बंद करिए। सो यू डू 4-5 टाइम्स लाइक दिस। नीचे या ऊपर है, नीचे या ऊपर है, नीचे या ऊपर है, या दिस यू डू फॉर ए joint position sensation. So we examine the posterior column sensation, fine touch, vibration, position sensation, joint position sensation. Next we will examine the spinothalamic tract, which carries the pain and temperature. So if we examine pain, that is enough. So same way how we examine the touch, we will examine in the same dermatomal distribution the pain examination. Okay, right. जब मैं ये टच करता हूँ तब आपको दर्द मालूम होता है, तब एक एक बोलना, ठीक है, right. So we will examine in the same distributions how we did for a fine touch.
1,
Yes, C2, this is C2,
1,
C3
1,
and C4 both, that is cervical plexus.
1,
C5,
1,
C6, C7,
1,
C8,
1, 1,
T1,
1, 1,
T2, T3 is axilla, nipple is T4, let us see,
1, 1,
T8, T10, T12,
1, 1, 1.
so next is L1, L1,
1, 1,
L2,
1, 1, 1,
L3,
1, 1,
L4,
1, 1,
L5,
1, 1,
S1,
1, 1, 1, 1.
S2. This is how we examine for the pain sensation. These are the general modalities of the sensation which you examine. Okay, there are some special cortical sensation which you have to examine. So which are the cortical sensation which you will examine? Okay, the tactile localization, 2-point discrimination, stereognosis, graphesthesia and sensory extinction. These are the things which you will examine in the cortical sensations. So we will examine one by one the cortical sensation. Tactile localization. How do you examine tactile localization? आपको आंख को बंद करना, जब मैं बोलता हूँ इस हाथ पर मैं टच करता हूँ, जहां टच करता हूँ इस हाथ में दिखाना मुझे कहाँ मैं टच किया वो प्लेस, ठीक है, राइट। आंख बंद, गुड गुड। So this tactile localization is localizing it. Okay. Next is 2-point discrimination. 2-point discrimination we have to ideally do by calipers. Okay, so he has to appreciate there are two impulses. Okay, two impulses but not the one impulse. The least 2-point discrimination, the least place where they can say there are two stimuli is in the lips, that is 1 mm. Sorry, in the tongue, that is 1 mm. In the lips it is 2 mm. In the tip of the fingers it is 3 mm. Tongue 1 mm, lip 2 mm, tip of the fingers 3 mm. Dorsum the palmar aspect of the hand 10 mm, dorsum aspect of the hand 20 mm, dorsum aspect of the foot 30 mm. The 2-point discrimination. So next is stereognosis. Stereognosis is identification of the form, texture and the meaning of the objects by the touch. So let us give him some familiar objects, let him identify it. आंख बंद करना, आपका हाथ को मैं कुछ चीज देता हूं, वो क्या है बोलना. आंख बंद करिए. क्या है? गुड. क्या है? पेन. क्या है? बुक्स. So this is stereognosis. The next is graphesthesia. Okay, graphesthesia, the known numbers you have to write on his leg and he has to identify the numbers. So let us write some familiar numbers on the leg and he has to identify it. मैं नंबर्स लिखता हूं, ये क्या नंबर है आप बोलना. आंख बंद करिए.
1 3 4 6.
Correct. So like this you have to write some familiar numbers and you have to identify it. Then the other two sensations which you can test is the pressure sensation. The pressure sensation is tested by putting a finger little deep pressure, applying a deep pressure with the finger, pressure sensation. This pressure sensation is carried by the same column, the posterior column, Then one more sensation is deep pain sensation. Deep pain sensation is tested by either squeezing the calf muscle or putting a pressure on the ulnar nerve or putting a pressure on the eyeball or pressing on the testis. Deep pressure. This deep pain, okay, is carried by the same fibers like the spinothalamic tract. The loss of this deep pain sensation by squeezing of the muscles of the calf is known as Abadi's sign, which you get in tapes dorsalis. The same pain sensation which is lost by squeezing of the testis is known as the Petrie's sign. Burnet's sign, the same loss of sensation if you press on the ulnar nerve. Okay, these three signs are seen in tapes dorsalis: Petrie's sign, Abadi's sign, Burnet's sign. Okay, so these are the sensation. One more sensory extinction I want to tell. For example, if the patient, if I apply two stimulus on right and left side, you should be able to take there are two stimulus. If there is a right parietal damage, if I apply two stimulus, left side he cannot appreciate. If left parietal cortex is damaged, right side he cannot appreciate. When I put a simultaneously, but I give the stimulus singularly, you will be able to identify the stimulus. That is sensory extinction. आंख बंद करिए. मैं कहाँ टच कर रहा हूँ? राइट साइड, लेफ्ट साइड और दोनों तरफ? दोनों. Yeah. Left or right. Yeah. So you can appreciate together. For example, if right parietal lobe is damaged, if I apply together, students, sensory extinction. So I told if two impulses are given simultaneously, they will be able to take there are two impulses. If one side of the parietal lobe is damaged, the contralateral side they cannot identify there is a stimulus. But if individually if you stimulate, they will be able to identify. For example, आंख बंद करो. मैं राइट साइड, लेफ्ट साइड और दोनों साइड टच कर रहा हूँ. लेफ्ट और राइट में. Yeah, so he is able to identify both the sides. For example, if right parietal lobe is damaged, you won't be able to appreciate the left sensation. That is known as sensory extinction. Same thing we discussed in the optic nerve examination. That is a visual extinction. This is a sensory extinction. Okay, right. So we showed how to examine the sensory system examination. Now we have to interpret it. Examination is one part, interpretation is the other part. How to localize the sensory system abnormalities. So we have examined the sensory nervous system examination, students. Okay. Now let us come to some of the patterns of sensory loss. Okay. So how, if at one pattern of sensory loss is there, what diagnosis it will give a clue. Okay. Different patterns of sensory loss will give a different etiological diagnosis. Okay. We have already examined the sensory system. Now let us discuss the different pattern of sensory loss will give clue to what diseases. See dear students, in the A, in the A diagram you can make out one side of the body there is a loss of sensation. If one side of the body including the face, if there is a loss of sensation like in the diagram A, the problem is in the thalamus. Okay, because ultimately all the fibers, pain, temperature, vibration, everything even from the face and from the opposite side of the body will go and synapse in the thalamus. So if right side thalamus is involved, there will be contralateral loss of all modalities of sensation. All modalities of sensation. If left thalamus is involved, there will be right sided loss of all modalities of sensation. Students, you see in the diagram B, in the face ipsilateral one side there is a loss of pain and temperature, and contralateral pain and temperature of the body will be affected. This kind of a presentation, ipsilateral face pain and temperature, contralateral body pain and temperature, is a feature of lateral medullary syndrome. Lateral medullary syndrome. Okay, because lateral part of the medulla contains, on that day I told, lateral spinal thalamic tract, descending tract of the spinal nucleus of the fifth nerve, where both will be damaged. Producing a typical picture, like one side the face will be affected, the contralateral pain and temperature of the body will be affected. The third pattern you will see, dear students, here there is a definite level. Okay, spinal cord, if there is a transection of the spinal cord at T10, at T12 level. Below that level, all the modalities will be lost, whether fine touch, vibration from the posterior column, or pain and temperature from the spinothalamic tract. So all the modalities will be lost below one level. Okay, so there is a definite level in spinal cord, all the modalities will be lost. See the interesting thing in the D. Here only a part of the shoulder and the hand will be affected. Above and below it is normal. This type of sensory loss is known as suspended sensory loss. You get in intramedullary tumors, that is syringomyelia. So there will be loss of pain and temperature, dissociate anesthesia. And why I told pain and temperature will be affected? Because those fibers are situated very close to the central canal, okay, of the spinal cord. So those fibers will be damaged by the syringomyelia. So there will be a loss of pain and temperature in the shoulder and the hands. Above and normal it will be, above and below it will be normal. This is called a suspended sensory loss. See here it is affected, but above and below it is normal. Students, you see the E, where there is a glove and stalk anesthesia. So where you get glove and stalk anesthesia? Peripheral neuropathy. See the different pattern of sensory loss, how it is giving a clue to the etiology. Okay, so glove and stalk anesthesia is seen in peripheral neuropathy. So next, students, here you see ipsilateral, fine touch and vibration, contralateral pain and temperature. Okay, so if there is any compression of the spinal cord by the extramedullary compression, okay, ipsilateral fine touch and vibration will be affected, contralateral pain and temperature, along with ipsilateral cortical spinal tract weakness. What is the syndrome? This is known as Brown-Sequard syndrome. Okay, so Brown-Sequard syndrome you get in a compressive myelopathy, ipsilateral corticospinal tract involvement, ipsilateral fine touch and vibration, contralateral pain and temperature will be affected. Okay, right. This is Brown-Sequard syndrome F. G, if there is one radiculopathy or if one nerve is affected in the upper limb, and H is if a radiculopathy or one nerve is affected in the lower limb. Okay, you will get a pattern of sensory loss like this. The other two sensory loss which are not given in the diagram are, one is a sacral sparing, which I told in intramedullary lesions there will be a sacral sparing like ependymoma or syringomyelia. And another is saddle anesthesia. Saddle is the part where if a person sits on a horse, that part of the buttocks is known as a saddle. Okay, if conus is involved, conus is a part of spinal cord where S2, S3, S4 which supplies the conus medullaris. So if conus medullaris lesion is there, S2, S3, S4 which supplies the perianal area, there will be a loss of sensation. That is saddle anesthesia. So dear students, if these are the patterns of the sensory affection, then you can make a diagnosis. Oh, this pattern is there, this is the etiology. This pattern is there, this is the etiology. Okay, right. I want to discuss even sensory supply of the hand along with the discussion of the examination of the sensory nervous system. See, this is the palmar aspect of the hand. Okay, the palmar aspect of the hand, the lateral 3.5 fingers is supplied by median nerve, the thumb, index, middle half of the ring finger. Okay, the medial 1/3 is supplied by ulnar nerve. This is the palmar aspect. Okay, in the dorsal aspect, you see here dorsal aspect. Okay, the lateral 3.5 is supplied by the radial nerve posteriorly. Okay, and the medial 1.5 finger is supplied by ulnar nerve. Okay, ulnar nerve. So the ring finger, okay, the ring finger has all the three nerves. Palmar aspect, it has a median nerve, ulnar nerve. Dorsal aspect, it has a radial nerve and ulnar nerve. So ring finger has all the three nerves supplying it. Okay. See, usually if there is a dissociation of the sensory system abnormality, for example, if only pain and temperature is affected, or only fine touch vibration is affected, like these kind of things you get where these fibers are situated at a distance, for example in a brain stem or in a spinal cord. Whereas if peripheral nerve is affected, or if thalamus is affected, or if a root is affected, all modalities will be lost, because all the modalities will be carried there in a peripheral nerve, in a thalamus and in a root. Whereas in a spinal cord and brain stem, the fibers, the tracts are away, so you get a dissociate anesthesia. Which are the conditions you get dissociate anesthesia? As I already told, the syringomyelia, the pain and temperature fibers are very nearer to the spinal central canal. They are the one which will get damaged. So there are loss of pain and temperature, but the posterior column sensation will be normal, fine touch and vibration. Anterior spinal artery thrombosis, okay, because these spinothalamic tracts are anteriorly situated, they are the one which will get damaged. The posterior columns will be spared. Lateral medullary syndrome, I told ipsilateral pain and temperature will be lost on the face, contralateral pain and temperature will be lost on the opposite side of the body. There also you get a dissociate anesthesia. The extreme of dissociate anesthesia you get in Brown-Sequard syndrome, when there is a press of the spinal cord from the one side, ipsilateral fine touch and vibration will be lost, contralateral pain and temperature will be lost. That is the extreme of dissociate anesthesia. Then small fiber neuropathies like leprosy, diabetes, amyloidosis, you get dissociate anesthesia. Okay, right. Usually the peripheral neuropathy, they will affect the long fibers, so there will be a glove and stock anesthesia, but there are some peripheral neuropathy which affect the short fibers like porphyria and Tangiers disease, they affect the short fibers. The patchy sensory loss you get in leprosy, the recovery phase of the peripheral neuropathy, arachnoiditis, mononeuritis multiplex, you get a patchy areas of loss of sensations. Now, already I told in the theory part the pattern of sensory loss. Now, let us go from periphery to the center. If peripheral nerve is damaged, I told glove and stock anesthesia will be there if peripheral nerve is damaged. Coming to the spinal cord, okay, if in the spinal cord, Brown-Sequard syndrome is there, ipsilateral fine touch and vibration, contralateral pain and temperature will be affected. Then again, within the spinal cord, if there is a problem with the central canal, the spinal canal, there will be a dissociate anesthesia and suspended sensory loss. Again, within the spinal cord, if S2, S3, S4 is affected, there is a saddle anesthesia. The perianal area will be affected, you get saddle anesthesia. Then again within the spinal cord is central canal, if syringomyelia or ependymoma expands, you will have sacral sparing. Then go above to the lateral part of the medulla, lateral medullary syndrome, one side pain and temperature of the face, contralateral pain and temperature of the body will be affected. Still above you go, thalamus, full opposite side of the body, including the face, everything, all modalities will be affected, pain, temperature, fine touch, vibration. So right thalamus, left side of the body will be affected, left thalamus, right side of the body will be affected. Then still if you go above cortex, cortical sensation will be lost, which we discussed, how to examine the cortical sensation. So this is how you interpret and localize the sensory system examination. Now there is one more important entity, the organic sensory loss and functional sensory loss. Usually in your practice, people will come with functional abnormality, functional sensory loss. How to identify whether it is really organic or functional sensory abnormality? There are some points to say whether it is organic or functional. Okay. For example, if the patient say below umbilicus, I cannot appreciate the sensation. If it is a organic, usually the loss of sensation will be like this. Anteriorly it comes down and it comes like this. If it's a functional, exactly they will say like this, one circle, exactly at one level, functional people. Organic, it comes down like this it will come down. If it is a functional problem, there is abrupt change in the loss of sensation. They will say from that point they cannot appreciate anything, zero. Whereas organic, there will be a gradual loss of sensation will be there, not an abrupt change. Then the midline. The midline, if it is an organic, usually it stops before the midline because the overlap of the dermatomes. If it is a functional, exactly in the midline they will say they cannot appreciate the sensation. Functional, because of the overlap, it will fall short, the sensory loss. Here only it will fall short. Then splitting of vibration, which I discussed in the fifth nerve examination. The mandible, the forehead is a single bone, but a functional person will say right side of the bone he cannot appreciate, left side he can appreciate, which is not possible. The splitting of vibration. Then functional people, stereognosis will be normal, Romberg sign will be normal. Romberg sign will be normal, stereognosis will be, it won't be there. Stereognosis won't be there, stereognosis will be normal. Then short syndrome. What is short syndrome? Sight loss, hearing loss, olfaction, tactile loss. So all these four in one side of the body they will say I cannot see, I cannot hear, I cannot feel the sensation and I cannot feel the touch, which is not at all possible in CNS. No anatomical disease can explain this problem. Then peripheral neuropathy, usually once it comes to the knee, then only hands will be affected. But a functional person will say the foot is not able to appreciate, hand was able to appreciate. That is not possible. Only you should not appreciate till knee, then only hand cannot appreciate. So hand and ankle is a functional, hand and knee is organic. Next, suppose if patient say he cannot appreciate one finger sensation, for example middle finger. So there is one maneuver, okay, ask the patient to do like this, okay, either with the eyes open or closed you can do this, okay, do like this, then ask the patient to bring the arm like this, okay, I repeat, first hold the arm like this, then ask him to bring the arm like this. Suppose if he says the right middle finger not able to appreciate, okay, while holding here right middle finger, that when any person, even for normal person, when the hand is like this and brought like this, he will get confused with the right or left. For a functional person, definitely he will get confused, and if you again touch that finger which he told he cannot appreciate, either he will delay the response because of confusion or he may tell the wrong finger. But an organic person will definitely tell same finger. Then yes or no test. That means you tell the patient when I touch, if you can appreciate you tell yes, if you don't appreciate tell no. A gullible person who is having a functional problem, each time when I touch he will say yes, when I touch if he cannot appreciate or appreciate he will say no, because he don't know that he is appreciating, that is why he is saying no. He will be touching, he will say yes, he will be touching and he will be saying no. Why is he saying no? Because he is appreciated and he is telling no in the abnormal part. Yes or no test. So these are some of the tests to distinguish organic from a functional sensory loss. The one more test in the posterior column which I should have told is a Romberg sign. Romberg sign is the hallmark sign of posterior column dysfunction. So you should ask the patient to stand with both the feet together with the eyes open and eyes closed. With the eyes open, he will be able to stand properly. With the eyes closed, he will fall down. So let us show how to do Romberg's test. ये दोनों palm ऐसा close करिए, ओके, दोनों full close, ठीक है, right. आंख खोलना, खोलना. Yeah, so he has to stand like this with the eyes open, then ask him to close the eyes. आंख बंद करना. Yeah, he is able to stand. So there is no problem with the posterior column dysfunction. If there is a posterior column problem, then he will sways. So this is about sensory nervous system examination. So dear students, we showed and we discussed how to examine the sensory nervous system examination. Okay, right. One point I want to tell in sensory nervous system examination is, if there is a thalamus problem, okay, there is one syndrome known as Digerin and Rossi syndrome, where there will be increased threshold to all modalities of sensation with a severe intractable pain as though some flesh has been tearing. This is known as anesthesia dolorosa. Okay, that means they have an increased threshold to all the sensation, that is anesthesia dolorosa, but they are having a severe pain also. This is Digerin and Rossi syndrome in thalamic problem of sensation. Okay, now after examining the sensory nervous system examination, let us go to the gait.